Welcome and good afternoon. This is Elizabeth Hardig with the American Planning Association. We're excited to kick off our Healthy Communities Collaborative webinar. Before we move to the content, I did want to let folks know that you should see a chat box or a question box on the right-hand side of your screen. Please feel free to chat in your questions throughout the presentation. We've saved time for Q&A toward the end of our discussion. This webinar is being recorded, and you will receive a copy of the recording via email in the next day or two. And with that, I will hand things over to Dr. Tony DeLucia, who is a professor at East Tennessee State University and is the chair of our education subcommittee. Tony?
Yeah, Elizabeth, thank you very much. I hope everyone can hear me. I'm very pleased to see the attendance of our two webinars, this being the second of two that we planned with our education subcommittee. And I'll go through a couple of slides which are meant to orient you a little bit to the past history of what we are doing and where we plan to go with this. So I'm going to first of all read the mission statement of our group. The Healthy Communities Collaborative from the American Planning Association Interest Group, the planners and allied professionals. We're interested in fostering cross-sector collaboration, increasing capacity to support building healthy communities, and looking at various levels, various lenses, local, regional, state, or national level. And you see the kind of lowish promote healthy communities. And we just recently, since I was at the American Public Health Association, had a joint call to action. The organizations which had a little reception were the American Public Health Association, the American Institute of Architects, the American Planning Association, the American Society of Civil Engineers, the American Society of Landscape Architects, the National Recreation and Park Association, the U.S. Green Building Council, the Urban Land Institute. And you just might think that this is only a partial list of a widening group of people who, groups that and individuals who are interested in the important influence of the built environment on health. So why the collaborative? This pictoid really shows a circular process that, to me, it's kind of like a ratchet-sized size view of a logic model almost, where we're starting with building the movement, assembling the stakeholders, and finding ways that we can connect, and then finding ways that leverage from those connections can lead ultimately to resources and ultimately a ratcheting up of accomplishments that are going to be beneficial to communities. We'll talk about that during our discussion period. So here's a little bit about our structure. We have a chair, Kayleen Koch from New Jersey, and we have an advisor, Grace Kuhn from St. Louis, who have been very instrumental in getting us off the ground. We have quarterly calls, and we'll talk about one coming up later on this month. And the work so far has been done with bi-monthly calls from the three work groups. This is the education work group, which, because I'm in higher ed, has been a natural feature for me. But we also have a partnership outreach group, see the individuals there, and we have a policy work group. And we're provided support by a very capable support by Anna, Elizabeth, and Sagarsha. So this is just to show you a little bit of the momentum which is building from Plan for Health. And you can see color-coded on a map of the continental United States, and also with a yellow dot for Hawaii. The red dots, which was the first cohort of Plan for Health communities, the blue dots, the second cohort, and a yellow dots, the third cohort, Planners for Health and initiatives. And we think this indicates, again, this continuity and increased involvement across the United States in beginning to integrate planning very capably and with great intensity in health related initiatives across the board, with many, many different sites where it can be operationalized. So you can get involved. I think that's the wonderful thing about it. That's how I got involved. So if you want to find out more about our group, here's the information for our next quarterly call. It's really exciting to be on these calls and see what we talk about. We also have the subcommittee calls, but here's the information. And at this time, I'm going to stop my yakking and introduce our capable speaker for today, or presenter for today, Katie Parker. And Katie is with the Democracy Collaborative. And she joined the Democracy Collaborative in 2014. And she works there as a research associate within the Healthcare Engagement Division. And her work focuses on how hospitals and healthcare systems or health systems can leverage their business practices, such as hiring, purchasing, and investment, to support being inclusive, and including making that inclusivity for foster economic development. She's the co-author of the Hospitals Aligned for Healthy Communities Toolkit series, and she conducts research on promising practices in the field of anchor institution strategies. In addition to research, Katie provides facilitation support, let's take her up on that, for the Healthcare Anchor Network, and is the editor of the CommunityWealth.org newsletter. Katie has a BA in Environmental Studies from Brown University. She focused on political economy of food systems and natural resource-based industries. Prior to moving to DC, she worked for a community-based conservation nonprofit in the Swan Valley of Montana. She's experienced in local food procurement. We need to talk, Katie. Working as the purchasing coordinator of the Brown Market Shares program in Providence, Rhode Island. I turn this over to Katie Parker, and I'm very excited to hear what Katie has to say. Katie?
Hi, everyone, and thank you for that great introduction, Tony. And I'm really excited to be joining the Healthy Communities Collaborative webinar today. As Tony said, my name is Katie Parker, and I work as a research associate at the Democracy Collaborative, which is a DC-based research group. And I'm here today to talk about our Hospitals Aligned for Healthy Communities Toolkit series, which were developed with support from the Robert Wood Johnson Foundation to provide resources and materials to hospitals and health systems who are interested in thinking through how they can play a bigger role in community economic development and planning. A little bit about the Democracy Collaborative. We have offices in Washington, D.C. and Cleveland, Ohio, and we're really focusing on developing new models of economic development that expand community access to, ownership of, and ultimately control of resources and economic development processes. We've developed a framework that we call community wealth building, which is defined as a systems approach to economic development that creates an inclusive, sustainable economy built on locally rooted and broadly held ownership. So on the screen, you'll see a chart that kind of outlines how we see these things fit together between individual asset building, developing local and shared ownership, and the piece I'll be talking about today is figuring out how to leverage community assets such as local anchor institutions to support some of this work. And we care about this for a lot of reasons and think health systems are uniquely situated to do this work because we know there's an intimate link between health and wealth disparities, and that disparities are only growing. Up on screen are some statistics about health and wealth disparities that show that we really haven't progressed much, even though we know medical technology has improved, we know access has improved, but statistics around racial and economic disparities as they relate to health aren't really changing. We also know that place matters. This is a map of Cleveland, Ohio, and you'll see that in just an 8-mile span, there's an over 20-year gap in life expectancy between these two neighborhoods. The neighborhood on the right, 88 years, the neighborhood on the left, 64 years. But the interesting thing is you'll notice that the neighborhood with 64 years is located right next to a lot of world-class medical institutions. So we also know that proximity to care doesn't necessarily translate into differences in health outcomes. So my work at the collaborative is really focused on how can health systems and hospitals begin to shift the upstream determinants of health. This is housed within a broader research portfolio focused on the role of anchor institutions, which, as opposed to private business, are institutions that are rooted in place. So things like local government, universities, hospital and health systems, community and place-based foundations. These are institutions that aren't going to up and leave if a different location was more profitable. They're also some of the largest economic engines in our communities, often the largest purchasers of goods and services, large employers, and large investors in the form of their endowment portfolios. At the Democracy Collaborative, we're really focused on advancing what we call an anchor mission approach, which is a commitment to intentionally apply an institution's long-term place-based economic power and human capital in partnership with community to benefit the well-being of both. When we think of health systems, we know that they have a lot of assets at their disposal to improve community health, from clinical care to their government relations to community benefit grant activities. We're really interested in that bottom right corner, economic assets, so thinking how their business units can be better leveraged to support community health. And we think that these areas, while there is some progress, it's largely untapped. The hospital economic sector is really large, and many of those resources could be brought to bear to benefit their surrounding communities. Hospitals spend more than $780 billion annually on goods and services. We estimate that their investment portfolios total over $500 billion, and we know that hospitals and universities collectively employ 6% of the US labor force. This interest in unlocking this potential led us to develop the Hospitals Aligned for Healthy Communities Toolkit series with support from the Robert Wood Johnson Foundation. And these are meant to be concrete resources for health system staff in the areas of hiring, sourcing, and investment to begin to make moves on some of this work. The next part of the presentation, I'll talk about each of these areas of hiring, sourcing, and investing, give some examples, and then I'll show some screenshots from our online toolkit so you can begin to think through the functionality of these resources. The first toolkit is focused on inclusive local hiring. When we talk about local hiring, we're talking about matching jobs at a health system to the residents in the community who might be facing barriers to employment. So this includes training local residents for jobs at the institution, creating a pipeline so that those residents have access to the application processes, and ensuring that once they're in the institution, there are pathways for advancement and wealth building opportunities. Each toolkit includes 6 case studies from health systems across the country. In terms of hiring, right now I'm going to highlight the West Philadelphia Skills Initiative, which is based in Philadelphia, as the name would suggest. And they're a workforce intermediary that partners with a lot of anchor institutions, and they'll develop tailored training programs for local residents to meet some of the workforce needs of surrounding anchors. They've partnered with Drexel to develop a certified medical assistant pipeline program. And this helps to address one of Drexel's big needs, which was that they were experiencing really high turnover in those positions, which negatively affected their workforce bottom line. So they wanted to improve their retention rate. At the same time, the West Philadelphia Skills Initiative was interested in connecting local residents who they knew could perform in those jobs to those jobs. So the West Philadelphia Skills Initiative, in partnership with Drexel, developed a tailored training program that would help local residents understand the unique elements of working at Drexel and the skills they needed. They used a cohort training model, they used hiring managers in the training process, and they focused particularly on neighborhoods with high rates of unemployment. What they found was the program was really successful. It lowered turnover rates significantly and improved retention rate, and meant a real change in wages for those residents. The West Philadelphia Skills Initiative has developed similar programs with anchors in the areas of patient care, as well as IT and facilities and maintenance. When we talk about inclusive local sourcing, we're thinking about how to leverage the everyday buying of goods and services that a health system might do. While some things like pharmaceuticals are obviously difficult to procure locally, there are actually a lot of goods and services, be it distribution, facilities maintenance, office supplies, that could be procured locally. Our toolkit is focused on both the element of helping hospitals and health systems better connect to locally owned and diverse vendors in their communities and make sure that their contracting processes are accessible, but also to actually build up the supply base to meet the health system needs and to incubate new businesses. University Hospitals in Cleveland, Ohio has pioneered a lot of the strategies highlighted in the toolkit. They leveraged a large capital project to set really ambitious goals around working with minority women and LGBT vendors with a specific focus on Northwest Ohio. They were very successful in allocating spend towards those vendors, as you can see in the impact statistics. And a really unique element of the university hospital strategy is that they not only focused on existing businesses, but they did focus on incubating new businesses. They were part of an initiative called the Greater University Circle Initiative that brought together a lot of anchors, and they helped to incubate a nonprofit that would spin off worker-owned cooperatives that could help meet supply chain needs. Institutions in Cleveland were really interested in green businesses, so they worked to launch cooperatives in the area of local food, green laundry, and energy retrofits. So these companies are worker-owned, which means that local residents not only have a job, but they have a say in how the company progresses. They have access to higher wages, and because it's held by a larger nonprofit, they're able to integrate goals around community economic development into the core business structures. And University Hospitals has been able to support these businesses by buying from them. The last toolkit is on place-based investing. When we're talking about investing, we're talking specifically about how to leverage the treasury resources of an institution. So that might be cash on hand, so thinking about deposits in local banks or credit unions. It could be actual investments. It could be providing equity to local businesses or other initiatives. Or it could be investing real assets and helping to leverage things like real estate facilities for local economic development. Secours, which is headquartered in Marriottsville, Maryland, is a pioneer in this area, and they have a long-standing impact investment program which goes beyond the traditional social screens to actually make investments in things that promote health in the communities they serve. They have a long-term goal of 5% of their total investment portfolio and have invested $26 million to date. The primary way they do this is by partnering with local community development financial institutions, or CDFIs, to make investments in the areas of affordable food, housing, small business development, and other mission-aligned activities. They're also working on actually making direct loans with businesses and with housing projects. They were recently involved in a project that involved launching a community land trust in Richmond, Virginia. And they have also really worked on this side of business incubations. The photo on screen is a bakery that Secours was able to help provide a low interest loan to. So as I said, each toolkit has more of those case studies. So if you want to dive deeper and hear from those at institutions who actually did that work, we've really tried to focus on highlighting the stories of how these programs got started and to provide people with tools and templates so they don't need to reinvent the wheel. Everything is available for free at hospitaltoolkits.org. This is the screen you'll see when you navigate there. Each toolkit includes an animated explainer video, which goes over why we think that particular strategy is important. We have a glossary and key terms, as well as case studies from leaders in the field. And again, we really tried to highlight practitioner voices to get into the nitty-gritty of how this work actually gets done and to highlight some of the barriers and obstacles that health systems might face. Each toolkit also includes a detailed infographic, which goes over some of the processes that will need to be developed at institutions, and there are detailed strategy descriptions that accompany the different pieces of the infographic. We do have hard copies available. If anyone is interested, feel free to email me. And then each toolkit also includes this section called Diving In, which we hope is a way for people to identify quick wins within their health system. So things like quick policy fixes that can really make a difference, practice upgrades such as position descriptions to hire for, and a readiness checklist to help either someone within the health system or a partner who's hoping to partner with an area health system. We then wanted to provide some worksheets to actually help think through how a program would be designed at an institution. So on screen is the set of worksheets available for investment. So there are resources on how you would create a form and template to work with local businesses, or how you would begin to track your investment dollars and bring Treasury staff on board. The overcoming barriers section, we highlighted some of the most common issues and challenges we were hearing from people and paired those with the solutions we are finding in the field. And then lastly, each toolkit, we wanted to actually connect people with what's been developed so that they don't need to reinvent the wheel. So each one has a tools and templates from the health systems that are highlighted in the toolkit. And that includes everything from agendas for meetings to RFPs for the procurement to program brochures. And we hope that people are able to connect with the people highlighted in the toolkit and really foster peer learning opportunities. And that's been a big focus of our work recently. We recently launched the Healthcare Anchor Network, which has grown to include 31 health systems from across the country who are pioneering some of these strategies. We officially launched in June of this year and have an upcoming meeting in December. The network is really focused on thinking through how to enact the strategies discussed in the toolkits, and we are really excited about that because of the potential that these health systems have. Collectively, they employ more than 1 million people, purchase over 50 billion in goods and services, and have over 150 billion in investment assets. Members of the network participate in what we call anchor mission implementation groups, where they have peer learning opportunities between staff in the different toolkit areas and are able to talk candidly about the barriers they face in their work and brainstorm solutions. We have biannual meetings and also host webinars and calls very similar to what it sounds like this collaborative does to foster peer learning opportunities. So if you are interested in the toolkits, they are available online at hospitaltoolkits.org. Everything is available via PDF download. We do also have hard copies of the toolkit, which we would be very interested in mailing to any health systems and hospitals that are interested in this. And if you have any questions, ideas, feedback about the toolkits, or are interested in connecting with health systems in your area, please feel free to reach out, and I'm excited for discussion.
Thank you so much, Katie. That was a fabulous overview and 3 toolkits in one, really, which is wonderful. Please feel free to send in your questions using the chat box that should be on the right-hand side of your screen. We've got quite a few coming in already, and a lot of folks, it sounds like, may have been on our previous webinar where we were talking with Julia Resnick from the American Hospital Association around the community health needs assessment and really how could planners get engaged in a collaborative and working with hospitals. And I think this is just a great way to build on that conversation and to remind us that these anchor institutions have a lot of potential dollars to invest in our neighborhoods and cities and towns. So that's fabulous. The first question that I will share with everyone is actually just what we were discussing before we hit broadcast. How are folks thinking about anchor institutions if they're in rural communities or very small towns? And I wondered if you or Tony, if you have any thoughts about how rural communities fit into this anchor institution conversation.
I can talk about that a little bit. Although a lot of the examples we do highlight are in large cities, we do have health systems as part of the network that have a rural footprint and are able to pioneer some really powerful strategies. One area where we're seeing a lot of potential is in the development of renewable energy. So Gunderson Health System in La Crosse, Wisconsin has taken place-based investment, but dedicated their investment portfolio actually to moving towards 100% renewable energy, but those are renewable energy projects that also create jobs. So they're focusing on wind energy and biomass and have actually created facilities to do that. Another area where we see a lot of potential is in the development of regional food systems. One of the case studies highlighted in the procurement toolkit is Charleston Area Medical Center in Charleston, West Virginia. And they did their community health needs assessment process and realized that it was actually job security that was one of the biggest issues they were finding in communities. And they made it a part of their implementation plan to grow the regional agricultural sector as a way to create good jobs. And they focused some resources on building up the capacity of local suppliers to meet their needs. So that means food safety certification trainings and partnering with the local USDA extension offices to make sure local vendors are able to connect to the medical center. So I think in the space of that value chain production and really thinking about whole sectors, be it renewable energy or food, rural health systems are actually pioneering some of these strategies.
This is Tony DeLucy. I'll just add that there was a report in about Southwest Virginia called Farm Shoring in Virginia or Southwest Virginia. It came out of Virginia Tech, as I recall, and it really talked about jobs from the Washington, D.C. area that would, instead of being offshored, go to rural Southwest Virginia. And some of them were with regard to the data needs of hospitals. You can imagine the electronic medical record and things like that. I believe that that would be something for people to look at, because there were also efforts related to quality of life, because people moving into some of these places would need things that hospitals would be very proactive on, such as physical activity and healthy food. So you would see the natural synergies with the population.
That's great. Thank you both. And I'll just put a quick plug in for the Plan for Health website, plan4health.us. We do have quite a few of our communities who were working in rural areas, so populations of 3,000, for example, in Ajo, Arizona, or in Eagle County, Colorado. They were working with local jurisdictions that had, I believe, the smallest town was about 400. So some great examples about applying not just anchor institution or healthcare focused strategies, but more healthy communities work more generally speaking in rural sites as well. We are just about out of time, but I did want to maybe ask this one more question from folks. This is about making the connection between emergency preparedness and responding to disasters. And I just wondered, Katie, if you'd heard from any of your anchor institutions about connections between their work and resiliency and preparedness efforts.
This is an area that we haven't focused on formally, but I think has a lot of potential. The one space I actually have talked about it with staff at health systems is an interest in localizing their supply chain as an emergency preparedness tool. And the idea that if suppliers are local, they are more resilient, and also building up the capacity of local suppliers is a strategy to do that. But in terms of broader conversations health systems are facilitating around emergency preparedness, I'm sure they're happening, but we haven't been asking that question yet.
As you were doing the presentation, Katie, I couldn't help but see you emphasized green several times. And at the recent public health meeting, there was a lot of discussion, of course, of climate change, and some of the words about heat vulnerability involved, the urban heat island. And so there would be, obviously, I think, some connections with that as a minimum starting point with cooling stations and some of the things that health departments and hospitals and emergency workers could really get involved in. Now, of course, there could be other things related to that, like, providing water and, looking at other smoke-related, wildfire-related issues, et cetera. But I think that there's really a good possibility. I have a respiratory background, so some of these things come up rather quickly for me.
Great, thank you. Thank you both. And I know we're already over our very short 30 minutes. I just really appreciate both of your presentations, Tony and Katie. This has been a fabulous discussion and seems to have resonated with our audience as well. Please look for a copy of the recording in your email in the next day or two, and feel free to reach out to Katie, of course, who's given her email address, or to health@planning.org if you'd like to learn more about the Healthy Communities Collaborative and how you can continue to get involved. So thank you again to you both, and with that, I will officially close our webinar.